Hello, and a very warm welcome to everyone joining us for this Select Science webinar titled Looking Ahead in the Clinical Lab, What's Next After COVID-19. My name is Cameron Smith. I'll be moderating today's presentation, and I'm delighted to be joined by our guest speaker, Dr. Jessica Van Allen from ZeptoMetrix. Please feel free to submit any questions you may have during the webinar. To do this, simply hover over the speech bubble icon on your screen and click to open the submission tool. So without further delay, I'm delighted to hand over to Dr. Van Allen and would like to thank her for presenting to us today.
Okay, today we're going to be talking a little bit about looking ahead in the clinical laboratory and really broaching the question, what's next after COVID? So, as a brief agenda, we're going to talk through some learning objectives. We're going to take a very brief look back at some of the pandemic struggles that have popped up. And then the meat of the talk is really going to focus on this idea of laboratory stewardship and how that can help us move forward. I'm going to talk specifically about a case study from Brigham and Women's Hospital that I found that I think offers a lot of great tools to do this. And then we'll kind of round out with some lesson learned and how to move forward. And lastly, I'll talk a little bit about how ZeptoMetrix can play a role in helping your labs move forward specifically. So to touch on our learning objectives first. These learning objectives, especially the first one, will really be an undertone of the whole presentation. I'll dive a little deeper into the last two more towards the end of the presentation. And what I hope is that by the end of this, you're able to use the information I present here to address these issues and move forward with a plan for your laboratory, or at the very least, have an idea of where you can start. So I think broadly, we're going to be talking about what are some mechanisms that we can use to move out of this pandemic stage stronger and more prepared for the next crisis. With the hyper focus we've had on COVID the last few years, I think it's been really easy to miss some of the more nuanced studies that have come out and evaluations of the field as a whole that have started to come out. And I hope to highlight a few useful and important studies that I found that will offer some tangible ideas for how to move forward. And now we're going to take a really brief look back at some of the struggles that have popped up for the laboratories. So really, I think we could probably fill a whole presentation with the headlines about all of the things that went wrong during the pandemic, right? Specifically in regards to clinical and diagnostic laboratories, between things like staffing shortages, reworking lab schedules and lab spaces to maintain a safe work environment, supply chain disruptions, and this constantly changing and evolving virus. I think laboratories and laboratory staff were really stretched to their breaking points. And what I think this pandemic did was made weaknesses in our systems really obvious and kind of exacerbated some of the existing constraints and pain points and issues that were already there. So, briefly and broadly, what has the pandemic taught us? I think number one, returning correct diagnostic results in a timely fashion is a really key priority. And secondly, the role of advanced microbiology diagnostics really must be clearly articulated to move the field forward. We have to consider, are the current standards of care working? And if not, how can we improve the current standards of care to help us move forward better and more efficiently? And lastly, again, very broadly, laboratories may have to now adapt to do more with less. And I think you'll see some of the molecular diagnostic developers out there start to try and fill some of the gaps with things like higher throughput methods and automation. But it's still something that laboratories need to consider. And also, something labs themselves can do is revisit some of your standard operating procedures and revisit your quality management system to make sure it's functioning as you need to adapt to this new normal. And really down this box at the bottom here, the undertone of this talk is going to focus on diagnostic or laboratory stewardship. I'll use those terms interchangeably as a path forward to address these issues. So laboratory stewardship. I think to begin talking about laboratory or diagnostic stewardship, we really need to start back with antimicrobial stewardship. And specifically, that is improving how antibiotics are prescribed by clinicians and used by patients to hopefully improve the efficacy of antibiotics for use in the future. There's a statistic I found that 30 to 50% of prescribed antimicrobials may be overprescribed or unnecessary. And I don't think this is new, but really this has come about largely, I think, because there's historically speaking, been a pretty slow turnaround time for the diagnostics. Some of our older methods, like culture-based methods, are not very fast. So physicians, in waiting for these diagnoses, had to treat empirically first. But I think all of the ideas behind antimicrobial stewardship can easily be translated into the clinical laboratory, specifically in regards to ensuring things like the correct tests are being used on the correct populations for the correct reasons. And this is really an international effort and movement. The CDC, the WHO, the European Committee on Antimicrobial Susceptibility Testing all have action plans in the works. And they've really all kind of started at least 20 years ago when it started to become apparent that many of the bacterial isolates out there were resistant to commonly used antibiotics. And kind of a startling statistic I found is that between 2000 and 2015, global antibiotic consumption rate increased by almost 40%. So this is something that is really, at the forefront of what I think groups are trying to address. I mean, really, the ASCMID, their explicit goal on their front page is talks about strengthening the role of clinical microbiologists and infectious disease specialists at the European level to kind of approach this crossroads to figure out, solutions moving forward. I really liked this visual here on the left that shows kind of the interplay between diagnostic stewardship and antimicrobial stewardship. So we all know, it'll start with a patient coming in. They receive a clinical evaluation from the healthcare provider. And that's where the diagnostic stewardship work would come into play. So the healthcare provider would have to consider, what is the right test to order for this particular patient at this time and in the right time frame. So they order this test, and for the purposes of today, we'll really be talking about, rapid molecular diagnostic tests. So the order goes to the laboratory, the technologist performs the test and sends the result back to the healthcare provider. And again, this is where our antimicrobial stewardship comes into play, because then the onus is on the healthcare provider to, interpret the data correctly, to prescribe the correct antimicrobial in the right time frame, and then adjust as needed. So then it'll go right back to the patient, and either this cycle continues or it ends and the patient gets better. So if we're looking specifically at laboratory stewardship, the WHO has a definition from what they call their GLASS manual, the Global Antimicrobial Resistance Surveillance System. And they define it as coordinated guidance and interventions to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. And they state that it should promote appropriate, timely diagnostic testing, including specimen collection and pathogen identification, and accurate, timely reporting of results to guide patient treatment. Billions of tests are performed in the US alone each year. So multiply that, from a global perspective. And about 70% of downstream medical decisions are based on these tests, these pathology and laboratory tests that come out. And it's a statistic came out that 10 to 30% of laboratory tests performed in the US alone are either unnecessary or inappropriate based off of studies that have been done. So it's clear that both the underutilization and the overutilization of microbiological tests and diagnostic tools can have a negative effect on the management and outcome for individual patients. And I think it's in these instances that stewardship measures can be put into place to ensure communication between both the microbiology lab and the physicians, and also the patient, really, so that everything is clear and all relevant information is applied during the decision-making process. Diagnostic stewardship is also essential for infection prevention and control activities in healthcare facilities. Per the WHO, up to 7% of patients in developed and 10% of patients in developing countries will acquire at least one healthcare associated infection, or HAI. So, by getting timely and accurate microbiological results, we can help clinicians select the most appropriate treatment options, as well as implement necessary precautions to reduce the risk of, transmission and prevent outbreaks due to, for example, bacterial pathogens in healthcare facilities. Most healthcare-associated infections present a really significant economic burden at the societal level. And truly, a large percentage of these healthcare associated infections are preventable through effective infection prevention and control measures. And with the onslaught of these new technologies, and especially with point of care tests coming up over the last 10 years, turnaround times really can be greatly reduced, thus hopefully improving clinical decision making and patient outcomes. But to get to this point, clinical utility must be proven over the current standard of care to begin to implement these systems. So what is clinical utility? We want to consider, is it adding value for patient management? Do the results provide information that it's of value to the patient and the provider in terms of decision making? There are many different kinds of studies or trials that can be performed to help demonstrate clinical utility. Specifically, you can do prospective randomized control trials, observational case cohort studies, and retrospective case studies, just to name a few. But what you'll really want to look at is, where are you making improvements in some of these main areas? And right here, we specifically will call out clinical decision making, workflow, clinical outcomes, and cost. Those are the big four. And you can see in this visual here, in green, the priority for hospitals, blue is the priority for the payer, and red is really a priority for both. So what we want to consider is, where can improved efficiency in clinical decision making occur? How can we streamline clinical workflows? How can we achieve better patient outcomes while at the same time, offsetting or avoiding some extra costs? And I think before we get too far into this, I want to point out what I hope is obvious here, that I don't believe the onus falls solely on clinical laboratories here. What I'm offering is this perspective of how laboratorians and clinicians may approach this topic and issue going forward. This whole diagnostic process encompasses much more than the laboratory itself, but for the purpose of our talk, I'll be narrowing the focus on the laboratory. So I did a literature review and found four studies specifically that I think did a really good job of showing the process involved in showing clinical utility, specifically of PCR multiplex tests in very specific patient populations. I think there are some concerns that novel diagnostics may be becoming too complex for non-infectious disease physicians. However, I think with appropriate stewardship and intervention, I think which you'll see in these papers, results from these multiplex panels can provide really valuable clinical information in a very short time period. And I think this data, coupled with other factors such as, patient history, what the, circulating infectious disease landscape looks like, et cetera, could have an important impact on patient outcomes. One phrase that I've been reading recently that's been popping up is this point that detection does not imply causation. And I think that's probably the most important consideration to have when interpreting these kinds of data. And really, that's become pretty clear, I think, throughout the pandemic, that just because you detect it, especially at the nucleic acid level, what a lot of these tests do, it doesn't mean it's necessarily the main culprit. So, treatment decisions cannot be made in a vacuum, which I think we all well know. So I don't think that these multiplex assays are necessarily the be all end all, but you can use them coupled with what we already know, and in working with physicians, pathologists, clinicians, taken together, I think this data could very well decrease misdiagnoses and mistreatment, especially with, antibiotics for starters and moving forward. So we're going to jump right into each of these, and I'll do a very brief overview of each of these four papers. So in this study, the Diagnostics Committee of the Infectious Diseases Society of America conducted a comprehensive review of the respiratory molecular diagnostic literature specifically, and they approached this with a couple goals. They were looking to categorize clinical situations for which the current or available body of evidence supports viral and bacterial testing. And they also wanted to highlight nuances in results interpretation that impact patient management and, of course, antimicrobial stewardship, and to really try and identify critical knowledge gaps to guide future research. And the figure here that I'm showing is a conceptual model that the authors derived of the critical components of diagnostic tests efficacy. And they determined that, on the ground effectiveness may depend as much on the logistics of testing and the response to results as it does on the, intrinsic built-in accuracy of the nucleic acid amplification tests themselves. And they reached a couple conclusions in this study that, one, upfront multiplex testing may be most cost effective in pediatric patients specifically. And they found that using multiplex testing can reduce unnecessary antibiotics and interventions like chest radiographs. However, if we're looking in other patient populations, and they specifically mention the adult outpatients during flu season population, testing for something like influenza alone may be more cost effective than using one of these multiplex tests. And, from the end of this study, they really came to the conclusion that oftentimes multiplex nucleic acid amplification tests make clinical sense for very specific populations, immunocompromised infants, critically ill patients with pneumonia specifically. They narrowed down these groups that they really would have the most impact for. And they do also offer a proposal of recommendations for some future respiratory diagnostic studies that can help fill in the gaps. The second paper that I reviewed looked at a gastrointestinal PCR panel, and they basically compared patient populations that received a GI panel test, so a rapid multiplex PCR GI panel test, compared against historical controls or a retrospective test, really. So they found that patients who had samples tested by the GI panel had fewer interventions, again, fewer additional stool tests, fewer imaging studies, and fewer days on antibiotics. And they found that overall healthcare costs decreased in the GI panel group compared to the control group. They also referenced a study out of the UK that had similar findings. And how they broke it down was that although lab costs were increased with the multiplex test on its own, isolation costs were decreased. So, the cost of the test was a little bit higher, but what the results from that test did was lead to shorter stays in the hospital, thus decreasing the overall healthcare costs. And they determined that new, more rapid and comprehensive methods like this multiplex GI test may lead to increased stool testing and pathogen identification. They pointed out that numerous patients that present with acute gastroenteritis don't ever actually get an infectious disease workup typically because of the low sensitivity historically and the long turnaround time of conventional diagnostic methods. So they really highlight here the usefulness of this multiplex GI panel. The third study, we're back at respiratory pathogens again. And they found that in this study that targeted influenza virus testing alone may be a more cost-effective approach for adult outpatients with uncomplicated upper respiratory infections. This is kind of the same conclusion that was reached in that first paper. And they surmise this because they believe that turnaround time will likely exceed, the time of the office visit if you're using a multiplex assay. So they stated that, these targeted tests, which are typically a little bit less expensive than the multiplex, may actually be better for these adult outpatients who, like I said, are presenting with uncomplicated infections. So you'll be able to get your result, by the end of your doctor's visit. And then if it ends up, being negative for the influenza, then you can move forward to more interventions. Implementation of multiplex testing must be paired with education and antimicrobial stewardship, they concluded, really to discourage the use of antibiotics, of errant antibiotic use for such patients. And they concluded here that it's possible that multiplex testing may be more appropriate in preventing transmissions in groups such as infants and immunocompromised patients, because these groups specifically have a higher risk of developing really serious sequelae from lower respiratory tract infections. One thing they pointed out that multiplex testing can help with is that it can identify patients co-infected with two or more viruses, which is typically associated with higher mortality rates in young children and immunocompromised groups. The clinical significance of this co-infection really isn't fully understood, but by using these tests and identifying that, we can hopefully move forward there and better understand what these co-infections are really doing in patients. And lastly, this final paper looks at a rapid multiplex PCR blood culture identification test. So what they did here was compare three different groups: a control group that used the historical methods, a group that received a rapid multiplex PCR test, and then a third group that got that same rapid multiplex PCR test, but had added stewardship measures. So in the PCR only group, the results of the rapid test and the comments of it regarding optimal antimicrobial therapy were communicated to the service or the physician by telephone by laboratory technologists, and they were entered into the electronic medical record in real time. They state that gram stain positive blood cultures that had negative PCR results were reported with gram stain results only. But if we're looking specifically in the multiplex PCR and antimicrobial stewardship group, the test was performed and reported in the same as the non-stewardship group. But in this case, an infectious disease clinician or a pharmacist was paged with the results 24 hours a day, 7 days a week. So the subject's PCR result and their medical records were reviewed in real time, and the primary service or consulting infectious disease physician was contacted immediately over the 3 days following enrollment if a modification to antimicrobial therapy was deemed appropriate. And discordant results in this instance between the PCR test and the conventional identification testing were reviewed in real time by the bacteriology laboratory directors. You can see those were the kind of interventions that were used to distinguish the rapid group and the rapid with stewardship group. And what they found was the use of rapid multiplex PCR tests led to more judicious antibiotic use. The rapid multiplex PCR testing combined with antimicrobial stewardship resulted in the most rapid antibiotic de-escalation. They found reducing time to appropriate antibiotic escalation by 14 hours, which is what the multiplex PCR plus stewardship group did, was clinically significant in the management of patients with sepsis. They found a couple other additional advantages of the PCR test that they pointed out. It's a closed system. It can be used whether blood cultures contain gram-positive or gram-negative bacteria or yeast, and it doesn't require significant technologist training or time, which was a huge advantage. So I think coming back to this slide, if we take even just those 4 studies together, we can start to see a pathway towards clinical utility of many of these cutting-edge molecular diagnostic systems. And it was clear that stewardship in all cases increased positive outcomes. I think moving forward, what we have to consider is that informed decision making really has to be the name of the game to progress the field and continue to, or start to really implement these more multiplex tests in everyday use. So the big picture, what the examples I mentioned, I just talked about, taken with the studies already performed to show clinical utility of some multiplex test is that context matters. Like these tests show, you have to take into consideration things like community transmission levels and specific affected populations while taking advantage of these multiplexed assays with the hope that more of these diagnoses can be achieved correctly the first time. This quicker turnaround time can be a major advantage in specific populations and scenarios. And I think this just highlights the example where laboratory stewardship could really turn the tide for these specific populations of patients if some of these multiplex panels are able to reliably replace the current standards of care. Now, I know our focus today is on looking forward, but I think to do so, we have to really take a good look backwards and parse out the lessons we learned throughout the pandemic. It's become very clear that COVID had a negative impact on non-COVID disease diagnostics across several different disease states. Um, Several examples have popped up in the literature of some misdiagnoses in instances where patients presented with respiratory symptoms and were screened only for COVID. So this was a report from the CDC that I looked at. So again, patients are coming in with these respiratory symptoms. Given the landscape and high instances of COVID in the population, they were screened only for COVID initially, or once they tested positive for COVID, they were not tested for co-infections. Um, Not only that, but STI patient care and the diagnosis of hospital-acquired infections were also impacted throughout the pandemic. There was an article from the American Journal of Preventive Medicine that found that pandemic had an adverse effect on sexual health screening by causing significant declines in testing for both men and women. And another report from the International Journal of Infectious Diseases found that overall, there was an increase in healthcare associated infection rates, especially in low and middle income countries throughout the course of the pandemic. In higher income countries, the studies were kind of mixed on the impact of COVID on hospital acquired infections. And I think this was likely, and the author surmised that it was likely due to, increased hygiene measures and implementation of standard infection control practices that were being advised by the WHO at a time. However, the systems that were available for tracking and monitoring this kind of data may also have suffered due to shifting the focus on COVID testing and monitoring. Um, Bloodstream infections are a significantly rising cause of morbidity and mortality in COVID patients. There was a recent presentation at the Making a Difference in Infectious Diseases annual meeting that described a study in which it was determined that viral, bacterial, and fungal co-infections were higher in COVID-19 patients, along with death rates. And the investigators cited studies suggesting that over 70% of patients hospitalized with COVID were given antibiotics. And that number indicated to them that overprescription that could also be driving antimicrobial resistance. So I think all these observations will kind of go hand in hand with how diagnostic developers will approach the market moving forward. It's no surprise that many of the test makers and the platform makers shifted fully towards COVID testing by either developing standalone COVID or including SARS-CoV-2 as a target in existing respiratory or influenza assays. And what they're doing now is turning their attention back to their core businesses, their tests that they had before the pandemic started. And many of these projects that were on hold from the pandemic are moving forward now. And what we'll see, it seems like, is a focus on adding more syndromic panels to testing, things like UTI, STI, healthcare associated infections, like I talked about, wound, some more in depth fungal panels, and really a focus on things like higher throughput instrumentation and adding automation to the systems. So, taking everything we've learned into consideration and understanding where the field in general is moving, we can really begin to imagine ways that labs can expand beyond COVID testing while working with what they already had. So some of these questions you can ask are, are you using each platform or instrument to its full capacity or capability? I think it's clear that rapid molecular diagnostics can play a crucial role in identifying pathogens faster. So how can you leverage the platforms you have in-house right now to do so? Or, if you bought a new instrument specifically for COVID testing, that was a huge investment, obviously. So if you have these platforms in-house, that aren't necessarily cheap to maintain. So you want to make sure you're exhausting the full spectrum of possibilities for testing on these platforms to get your greatest return on investment. Secondly, you want to consider, are you up to date on the instructions for use if you're running an IBD test, or really your laboratory's general standard operating procedures? Guidances and instructions may have changed and shifted as resources shifted throughout the pandemic. So if you had to adjust your SOPs due to things like supply chain issues or staffing issues during the pandemic, is it possible to make those changes permanent? Did they work for you? Were there lessons you can look back on now that can shift how you operate in the lab, maybe more efficiently? And this third point, which I'll talk about a little bit later, is how can you get the most out of your quality controls? Does your internal quality control plan reflect the IFUs for the tests that you're running? And for laboratory developed tests and IBD tests alike, are you running QC at an appropriate interval for how many patient samples come through? You need to consider some of the consumable materials in your labs. I think historically speaking, a number of hospital labs and clinical labs have relied on donor or positive patient samples as quality controls, but with limited staffing and resources available, I think it's worthwhile to consider the opportunity to purchase external quality controls. With these, you don't have to spend the time to grow, characterize, dilute the materials, or find space to store them long term. Plus, you'll get an incredible resource when you purchase a quality control from someone else in the technical support and troubleshooting, should you need it when you buy from a manufacturer. I really can't overstate enough the huge cost that poor quality control can put on a laboratory. You have to think about this if you're a clinical laboratory turning out patient results every day. If your typical QC runs pre pandemic were weekly or bi weekly, when your testing numbers went up, did your frequency of quality control runs also increase alongside that? And, moving forward, are you able to bring that down? Do you need to keep it up? You have to really do a thorough risk assessment of your quality system to address these questions. Now we're going to talk about a specific case study from Brigham and Women's Health Hospital that I think highlights, stewardship in general and provides some really good lessons I think that labs can use moving forward. So, if you're not familiar, Brigham and Women's Hospital is located in Boston, Massachusetts. And through their clinical laboratories, they process approximately 3 million specimens per year. And in this case study, they do what I consider to be a very thorough job stepping back and analyzing what worked for them as they changed and adapted to the pandemic. This study really highlights what I think is the true heart of the term stewardship, the definition of which I put above, showing, the responsible overseeing and protection of something considered worth caring for and preserving. And they provide right off the bat a great summary of the lessons learned during the pandemic. And they highlight very specific resources they turn to and ideas they use to adapt and succeed amidst the chaos and constantly evolving landscape that was really brought about. I'm not going to read through every single thing on this table, but I do think it's worth listening to. The lessons they point out. I'll just highlight the lessons are number one, diversifying your SARS-CoV-2 PCR testing methodology. I think that can probably be applied across many disease states, and they offer some options like multiple testing platforms, consolidation of specimen processing, and things like that. The second lesson they highlight is having your informatics team at the table. And what they did, and I'll talk about that in the next slide, is they really worked closely with bioinformatics and their informatics team to develop algorithms and create dashboards to help them kind of move and prioritize where testing needed to go and figure out which tests should be used for which patients. Lesson three, which kind of goes into that, is communicate and collaborate. You want to make sure your laboratory is engaged and included in these decision making opportunities, and establish relationships with researchers that could offer additional health or testing capacity, et cetera. Lesson four, they focus on anticipating, planning for the worst, hoping for the best. And they did things like trend, commonly used tests to kind of predict what they would need when. And that kind of helps you when you're considering things like supply chain issues down the line, or decreased staffing due to someone being out from COVID. And lastly, their lesson five, reimagine and step outside your comfort zone. I think everyone was pushed outside of their comfort zone during the pandemic. So really trying to make the best of the situations that were given, and figure out how to leverage, people who had to work virtually, and use that to the best of our ability. So again, I really encourage you to check out this paper. They do a really great job highlighting these lessons and challenges, and give tangible steps to move forward. And so one thing, like I mentioned, they developed with their informatics team, working really closely with laboratory directors and the infectious disease and control people, to track testing volumes and positivity rates, as well as to electronically triage and direct specimens to different assays in this effort to maintain optimal efficiencies. So with this information, they developed an algorithm to direct specimens to certain assays based on patient-specific criteria and required turnaround time. So, if you look at this, so for example, ambulatory testing arrived in laboratory barcoded at the same time of collection with either send out testing, or testing to their Center for Advanced Molecular Diagnostics, which has a longer turnaround time assay, while the most urgent specimens arrived with a barcode for the in-house rapid turnaround time test. And they determined that this algorithm is adaptable and can change in real time, as they responded to things like supply shortages or adjusted to changes in testing volumes. And they mentioned that they've also since adapted the algorithm for the respiratory season, which requires not just SARS-CoV-2, but obviously influenza, RSV, and other respiratory viruses. So that's all I'm going to talk about there. But to kind of bring it all together and review some of the lessons learned, I think if we use this case study from Brigham and Women's Health as an example, and the other studies I talked about, it's clear that a huge amount of coordination and collaboration had to occur to make their success possible. And I do realize that trying to implement all of their takeaways may seem like a really daunting task, and obviously ultimately a lot of work up front. But I don't think that this is an all or nothing scenario. I think networking to try and connect yourself with existing opportunities, things like another hospital system or a clinical lab that you can share resources with, or technology, or in terms of bioinformatics, if you don't have a set team, reaching out to a local university, a medical school, grad school that can help you with some of these bioinformatics, is really the key to getting the job done with less resources and time. And it's pretty clear that rapid diagnostics will only improve clinical outcomes if they are coupled with stewardship teams. And in terms of collaboration, I think all players in infectious disease testing, from laboratorians to physicians to even the assay developers, must make coordinated efforts moving forward to share information and data to make the movement successful. And leaning into technological advancements, especially in things like IT and bioinformatics, which is a really rapidly growing field, to share and collect data internally and externally, can have a broad positive impact on patient care. So lastly here, I'm going to focus on specifically how ZeptoMetrix can play a role in helping your lab move forward. So I think if we, again, go back to that Brigham and Women's Health analysis and look at their lesson number one, like I mentioned, you can really fill in the blank here for SARS-CoV-2. You should diversify, all of your PCR testing methodologies across disease states. And they mentioned things like multiple platforms, having those all available, validating various media and different specimen types, because those change depending on what's available, anticipating supply shortages by trending, keeping space open for ongoing validations and troubleshooting, which I thought was a really great idea. And all of these answers include some kind of, upfront labor. Validation and verification studies, training on new platforms, training new hires, routine QC, or even developing LDTs and troubleshooting all have some kind of upfront labor involved with them. And I think Septometrics offers a really unique control option for each of these instances, and I'll discuss that briefly in the next slide. Another interesting idea, especially during the pandemic, that came up is that laboratories produced a vast amount of data every day, more so probably than any other healthcare facilities. And one concept that has recently been discussed in the field, and specifically in the European Journal of Public Health, is the thought of laboratories as data aggregators. So experts in the journal went on to discuss how, as data aggregators, labs will enable better public health. So by compiling all of the data being generated so that test results can be automatically integrated with patient and location data, you can help generate customizable reports to be able to predict and hopefully trend public health issues. And ideally, it would get to the point where healthcare professionals will be able to evaluate disease trends early and easily to identify things like potential biomarkers that could signal the development of a specific healthcare condition, ultimately leading to earlier interventions. And I think at the end of the day, the quality of the data that you are generating matters. So with all of this data being generated, it's really of utmost importance that it be trusted, good quality data. And we need systems in place in our laboratories to ensure that the data being generated and used towards patient diagnoses, and hopefully ultimately trending and long-term studies, is accurate. And one way to ensure accuracy in diagnostics is through the use of external quality controls. Now, this isn't a novel idea, this is not new. Many accreditation and regulatory bodies explicitly recommend the use of third party external quality controls in the laboratory. And like I mentioned earlier, I think ZeptoMetrix offers a really unique solution in these areas with our natural and activated molecular products. So just to gloss over some of the highlights, natural controls are non-infectious. They are purified intact microorganisms, so they work as full process controls for your PCR-based tests. What's really key is that they're refrigerator stable. They don't need to be frozen. They can be stored in the fridge and taken out and are ready to use as is. They have a 1 to 2 year stability, and they're really developer preferred. They work across a variety of platforms, and we have a really large organism bank to work from. So there's a number of attributes that make Septometrics controls an optimal choice for molecular testing. And I guess it comes down to you to determine exactly what is most important and most relevant to your lab when thinking about quality controls. What are some of the most important considerations for the test that you are running? Is it that the material contains the whole intact organism, or are you okay with just RNA, DNA sequences? Is it ease of use that you like? If you're understaffed, or is it a lack of freezer space that you have, so you have a fridge readily available that you can store these and grab and go? And I think Septometrics is really in a very unique position in the industry, in a place between the diagnostic test developers and the end users in the labs who are running the actual tests. So we have this again, unique perspective and insight into the market, and have really strengthened in our ability to troubleshoot and offer insight to our partners and customers really across the infectious disease diagnostic field. And I think with this perspective, I think comes a responsibility and an opportunity really to work closely with laboratorians and clinicians every day to find solutions within their own laboratories using the resources at hand. And here I just highlight a few different areas that I can see that laboratories might need to use quality controls and how ZeptoMetrix can really fit into each of those areas. Whether you're doing research and development and you need things like a quantitative control with a known concentration, or a linearity panel to test, your limits of detection, we have a really broad organism offering in that realm. Or if you're, running routine QC and you're just looking for external run controls or controls to run on a platform or an LDT, we have qualitative multiplex controls that can help you there. Or if your lab, bringing on a new platform or developing a new test, and you want to perform validation and verification, either through a quantity or a quantitative control or just a verification and validation panel control, we have a really wide offering in both of those arenas. So I can see how ZeptoMetrix can fit in kind of very different stages of different laboratories globally. And I think many of the quality control solutions I just touched on can help labs really expand beyond COVID testing with limited resources. These solutions can apply across labs who run both IVD and LDT tests. Not only do we have agnostic controls that will work across multiple platforms, which can save you money and time, but we also do receive a lot of feedback from customers using our products in the field. And that, coupled with in-house testing we perform, gives us a really great insight into the performance of a majority of our control materials on various platforms and assays on the markets. Like I talked about, a lot of these assay developers are now moving towards women's health and STI, beefing up their respiratory panels, and focusing on, these GI and these blood culture states, which have been found to be really useful when using these multiplex tests. So, we are armed and ready to help laboratories adapt to this changing field, and address each of these disease states. So hopefully, I hope what you gain from this is that diagnostic stewardship opportunities are a clear path forward here. If you're struggling using old, outdated, time-consuming methods for infectious disease diagnostics, I hope you'll consider looking into some of the studies we talked about to show clinical utility on some of the newer rapid diagnostic tests, and really, how to expand to get the most out of what you have, assessing current situations or bottlenecks in the laboratory and potentially expanding testing on existing platforms. You may have gotten new platforms in-house specifically for COVID testing, but chances are the platforms offer a multitude of assays for other infectious disease states. Um, Thirdly, I think using third-party controls across platforms when possible, and for simple routine QC or training opportunities would be really effective for you. External quality controls can be far more cost-effective, especially in regards to the time it takes if you're using donor samples to acquire, characterize, generate, and store those options. And lastly, ZeptoMetrix, I think, offers a really great full process control for your PCR test that can mimic a patient sample to give a consistent, reliable result and an unbiased assessment of your processes every time. So with that, thank you, and I will take any questions.
Thank you, Jessica, for that interesting presentation. I hope that everyone listening enjoyed the webinar and found it informative. We will now move on to the last part of today's webinar, the question and answer session. Just as a quick reminder to those listening, please feel free to continue asking questions using the tab at the left of your screen. Simply hover over the speech bubble icon and click to ask your question. So the first question I have for our presenter today is, does Septometrics have recommendations for frequency of running QC?
That's a really great question. Unfortunately, there's not really a black and white answer here. That is typically determined by the assay manufacturer. If we're talking about, rapid or multiplex PCR tests that were referenced in the studies, and labs must follow those recommendations at a very minimum. But in many cases, they can run them more frequently if the testing load requires it. And really, every lab is responsible to generate their own internal quality control plan, where these stipulations should be spelled out. I do think that CLSI actually does offer some really helpful guidances in determining what and when to run quality controls in molecular diagnostics. And I'd urge anyone looking into writing their own plan or trying to figure out where to start there.
Okay, thank you. The next question I have that's just come in asks, you mentioned that using donor samples or patient samples isn't ideal. Could you just expand on that a bit further?
Sure. I think in some instances, donor patient samples serve a role, have served a role, continue to. They're free, so and available. So obviously that's always been a draw, and they're actual patient samples. So you're getting a nice full process control. But now there are quality control options by third-party vendors, like I mentioned through ZeptoMetrix, where you can really get a control that is full process that mimics a patient sample and has the whole intact organism present. But not only that, but they have the advantage of being non-infectious and refrigerator stable. So you don't have to worry about finding freezer space, or you don't have to worry about the samples degrading by repeated freeze thaws. And I think, like I also mentioned in my talk, I believe that you have the advantage of being backed by, if you're Zeptometrics specifically, being backed by our technical support and customer service. If you do ever run into any issues or you're trying to, figure out a workaround. So you're not stuck troubleshooting on your own. So, really, the major plus in using an external quality control is the time savings. I think that's associated with buying them rather than taking your donor samples, characterizing, diluting, storing, that kind of stuff. So I think more and more, the idea that time is money, especially working, in this post-COVID, being understaffed, under-resourced. I think turning to external quality controls can really help labs move forward a little bit more efficiently.
Great, thank you. The next one I have for you asks, as COVID begins to fade, what tests are useful for long COVID and related post-viral issues that are similar, like myalogic encephalomyelitis?
That's a really great question, and I think that's a part of the field that's really starting to evolve. I think obviously researchers have really been working to kind of characterize long COVID, and right now I think that's where they are. Is they're trying to, develop a way to kind of diagnose, if you can diagnose. One thing I think they've struggled with is, confirming an actual COVID diagnosis to then be able to rule out things like rheumatoid arthritis or lupus. I think that where the symptoms can mimic them. And I think what we'll see, at least what I'm seeing in the field, is that you'll probably see more work towards designing or diagnosing long COVID by identifying things like biomarkers that pop up with some of this post COVID immune system inactivation. I know that they're looking potentially at targets, things like inflammatory cytokines like IL-6 and IFN, and these kind of these biomarkers that can be measured with flow cytometry, things like that, to be able to, diagnose post-COVID syndromes. And right now they're not quite there. So I think there's a lot of call to action and call for data and insights to be able to determine that. So that will be a really, really interesting field to keep an eye on moving forward for sure.
Great, thank you, Jessica. I have a follow-up question for you on a similar point around, as COVID fades, and this asks, do we need very rapid at-bedside handheld tests for sepsis, since it can progress so rapidly and lead to so many deaths per year?
Yes, definitely. I do think that, especially at the beginning, I think we have a little better handle on it now, but at the beginning, patients were coming in and just getting treated very broadly for the symptoms that they were presenting. A lot of it with COVID or possible co-infections, and it's been seen to go hand in hand, kind of this increase in sepsis and I think developing rapid tests to one very quickly determine what the actual causative agent is will be instrumental in kind of decreasing the impact of things like sepsis and different blood culture infections. Absolutely, they'll be crucial, and hopefully they can become and replace, become the new standard of care to more quickly give us answers. Because as sepsis, it's time is money there. You don't have time to waste trying to determine what's going on. So I think that's one field in which you'll hopefully see these rapid multiplex PCR tests start to be utilized more frequently and more effectively.
Okay, yeah, thank you for your perspective there. We have time for one more question. So that asks, how does a lab begin to develop a laboratory stewardship program?
Oh yeah, great. There are a lot of resources out there right now. Like I mentioned at the beginning of the talk, the WHO and CDC, among others, all have what are called they call manuals in place in regards to diagnostic stewardship. They're usually closely tied to their antimicrobial stewardship programs. So I think finding case studies of other laboratories, like I provided, who have done it already, can provide really tangible, doable pathways. But these manuals that are released out there by WHO, for example, are very thorough, very specific. Um, and then another point I think, like I mentioned also, is that I think networking opportunities, local talks, meetings, conferences, whatever scientific groups you're a member of, kind of leaning into those communities and opportunities to reach out and see how you can kind of work together to build stewardship and help each other achieve these goals would also give you a really huge advantage alongside those manuals and those guides that are already in place.
Okay, well, I'm afraid that is all we have time for today. I'd like to thank our expert speaker, Dr. Jessica Van Allen, for today's discussion, presentation, and of course this Q&A session. And a big thank you to everyone joining us online for submitting your questions. We hope that you found this a really worthwhile session. If you have any other questions, please feel free to email myself using editor@selectscience.net, and I'll follow up with your questions after the webinar. Remember, you can download related resources in the tab at the left of your screen. This includes a certificate of attendance. And if you'd like to listen again to today's webinar, or perhaps invite a friend to listen, it will be available to watch on demand in just a few days' time. Goodbye, and thank you once again for joining us.